Hello, I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine. I'm a lung cancer doc, and it's a pleasure here to be with an esteemed faculty to discuss these cases, very challenging cases. So before we get started with case one, if we could just go around and introduce who we are, institution, our interests, and I'll start with Dr. Bala. Dr. Bala?
Hello, everyone. My name is Sanjeev Bala, and I am the Chief of Cardiothoracic Imaging here at Washington University, and my specialty is dealing with chest CT, chest MR, and occasionally correlation with chest PET imaging.
I'm Kristen Higgins. I am a radiation oncologist at Winship Cancer Institute of Emory University, and I'm an associate professor specializing in thoracic malignancies.
My name is Tom Stinchcomb. I'm a full professor at Duke Cancer Institute in Durham, North Carolina. My specialty is thoracic oncology. I am a medical oncologist.
I'm Varun Puri. I'm a thoracic surgeon at Washington University in St. Louis, and I'm a professor of surgery here.
Our next case is a 49-year-old male, current smoker with a history of stage 4 lung adenocarcinoma of the right lung, metastases to the bone and brain. The patient has been on first-line therapy with triplet therapy. We can talk about that, and on maintenance pembrolizumab, but has recurrence. I think this is one of the most common scenarios that we see in our medical oncology clinic. It's and potentially an unmet need. The PD-L1 is 10%, and the question here will be, what are the opportunities for second-line therapy? So this patient presented in April 2020 with cough and hemoptysis. The patient has an ECOG performance status of 1. The past medical history includes chronic back pain, anxiety, and reflux. The patient's social history is consistent with a 25-pack year history of smoking. He drinks alcohol socially and frequently uses marijuana. His family history is consistent with a mother with multiple myeloma, but there is no history of lung cancer within the family. So he gets imaging that's performed. Dr. Bala, do you want to walk us through what we're seeing here? We have a CT and a brain MRI.
Yeah, so we've got on the top image is a post-contrast enhanced CT through the upper thorax. And you can see that there is in the upper lobe this kind of spiculated mass with this rim enhancement. And then centrally, it's a lower attenuation, which is in keeping with a cavitary or a necrotic lesion, very characteristic appearance for a lung cancer. What's not shown on the image is that there were some lymph nodes that were commented on in the chest and in the neck, and left upper lobe, there were some nodules. And then the image below is a coronal post-contrast enhanced MR. And you can see that there's a ring enhancing lesion on the patient's right, just above the just to the right of the falx. And there, that is a classic look for rim enhancing metastasis on MR. So it looks like we've got a right upper lobe lesion with metastatic disease, with nodules on the left and brain lesion that's enhancing.
Okay. It does say that the MRI of the brain showed multiple enhancing lesions. I guess we're only seeing just one of them here on this
Correct.
cut.
Correct. And a lot of blood vessels that are kind of also enhancing.
Okay, so widely metastatic disease, multiple lesions in the brain, disease that's not only meted to the brain, but has a T3 lytic lesion, and does get a CT-guided biopsy of the right upper lobe mass. And we don't have next generation sequencing on this, but we do have PD-L1 of 10%. Just a teaching point here, Dr. Stinchcomb, it would seem that a lytic lesion in T3 may be an easy spot to get to for a biopsy. Just your thoughts on why or why not to biopsy a bone lesion in these patients?
We generally avoid the bone lesion just because the yield from next generation sequencing goes down because of the decalcification process, destroys the DNA. And so we discourage that. I think the main time we see that done is on the inpatient service where someone biopsies it, and then we wind up repeating the biopsy, which is a big patient dissatisfier, as you've experienced.
And Dr. Stitchcomb, we'll talk a little bit about the management of this. We don't have next generation sequencing, and I'm assuming it was done. We just don't have it. But when you're seeing these patients in your clinic for the first time, and this gets back to some of the things we were talking about before, do you order a liquid biopsy in these patients while you're waiting for the tissue next generation sequencing to come out? This is a smoker. He has a less likely chance of having a genetic alteration, but what's the diagnostic algorithm in your practice when you're seeing a patient like this?
So good question. I think there's been a lot of debate even within our group, what's the optimal sequence of doing this? Generally, we try and get tumor tissue. We generally use an outside vendor to try and get around 250 genes. But in the case where the patient is very symptomatic and there's an urgency to start the treatment, I will often send off the solid tumor sequencing as well as a liquid tumor biopsy. Or if I'm concerned that the tissue sample is too small and I'm going to wait 2 or 3 weeks and get that dreaded quantity not sufficient thing, I'll send off the liquid biopsy. I think we really need to make sure that these patients really get a broad sequencing. One of my thoughts when I heard this case was, what's the KRAS G12C status?
A rapidly evolving field by the day, given some of the new data that just has come out at World Lung. But certainly, exactly, I think we think of these genetic alterations that are targetable and are never smokers, but we're learning more and more about some of the genetic alterations that may be targetable and mutations that are associated with smoking, like KRAS G12C. So I think it's a good point. This patient has a biopsy of the right upper lobe mass. We already talked about the fact that it's an adenocarcinoma. Its PDL1 is 10%. We don't know the next generation sequencing. Dr. Higgins, can you talk? It looks like we've got 4 lesions in the brain. It says multiple on the MRI, but it looks like there was stereotactic radiation done to 4 lesions and 1 area at T3. Can you do these both at the same time when you're seeing these patients, or do you take them? Can you do T3 while you're doing the brain, or do these separate out when you're doing them?
Yeah, I mean, I try to get things done as quickly as I can so the patient can move on to systemic therapy once we have the results of the NGS, as Dr. Stitchcomb was mentioning. I would look at the T3 lesion and try to make a determination about whether or not it's appropriate for SBRT, which can be done in a single fraction. So I might get an MR and see if there's enough space between the cancer and the spinal cord, and if there's at least 2 millimeters, we could do a single fraction of SBRT to T3 and do a single fraction of 21 gray to each brain met. And you can do that in one session, which is a beautiful thing for the patient. So that's probably what I would do. Alternatively, you could do single fraction SRS, and you could also do 4 gray times 5 to the bone, or even 8 gray times 1. So yeah, you can get these done fast. You don't want to delay systemic therapy, and I think that's really the important point here.
Got it. And I have an unfair question for you that I've asked to some of your radiation oncology colleagues at your institution. How many lesions in the brain are really, what's the cutoff for SRS? Is it 10? Is it 15? I know it's unfair, but we are trying to move away from whole brain radiation therapy. So where do you draw the line? Is there a line?
Yeah, I mean, I usually say between 10 and 12. I get a little bit nervous doing more than 10 just because the mean brain dose gets pretty high at that point. And then it's like, well, what are you really saving the patient? And there's such a high risk for recurrence of intracranial disease after the SRS. But, I feel very comfortable doing up to 10 for sure.
Okay. Do you put these patients on steroids while you're doing what's your threshold for steroids, and how long should they be on it? I've run into this issue recently in my clinic, and I'm just curious, some of the nuances of care that I may be short on sometimes. How do you do this?
Yeah, so it depends. If the patient is symptomatic in terms of their brain metastases with neurological symptoms, headache, nausea, any sensory or motor deficits, then I will do steroids. I would typically start with 4 milligrams BID. And then when I see the patient back after the treatment, I'll start a taper. I like to get them off their steroids relatively fast. I tend to do 50% dose reduction every 3 to 4 days when I'm tapering. However, sometimes when the tumors are large and there's a lot of edema, that doesn't always work, and you have to do a slower taper. When the tumors in the brain are over 3 centimeters, then I think those are the people that are going to require a longer taper from their steroids. But into somebody that's totally asymptomatic, I don't think they need steroids. And especially if they have 9 sub-centimeter lesions and they have no symptoms, then it's perfectly fine to treat with SRS with no steroids.
Okay, that's very helpful. Dr. Stinchcomb, this is, this patient is really within our wheelhouse. This is what we see day in and day out. So I will ask you a lot of questions on this and some of the nuances of care here. This patient got carboplatin, pemetrexed, pembrolizumab, the Keynote 189 regimen. We've had some updates from that look really nice. And then got 3 further cycles of maintenance pemetrexed and pembrolizumab, and then went on to just receive maintenance pembrolizumab. So maybe I can stop there because there's a lot to discuss and unpack. We now have 9 approved immunotherapy regimens frontline for patients without an actionable mutation that are stage 4. It's head spinning sometimes to try to remember all the data and all the new regimens. Your go-to regimen in your clinic for patients, and are there cases where you won't use, let's say the PDL, I'm going to keep it PDL1 less than 50 right now. We'll tackle the greater than 50 in a second, but this patient's PDL1, as I recall, is 10%. What are you using, and are there alternatives that you're starting to look at, given some of the new data we've seen with 227 and 9LA and others?
Good question. There's differences among our groups. I think it's sort of fractionated the thoracic oncology community. Personally, I continue to use the carboplatin and pembrolizumab. I think the data is very good with that in terms of efficacy. The PD-1 CTLA combination is very intriguing, especially with the duration of response that we saw in that 227 trial. But the response rates are still lower, which is important because the chemo pembro trial had a very good response rate. And I worry about the additional immune toxicities, which are manageable, but are also real for the patients at this point. So I've not been convinced about the PD-1 CTLA combinations alone or with chemotherapy enough to change my practice, but I might be in a minority.
I think you're probably, I don't know. I think you're in the majority still. I think we're creatures of habit. It's tough to shift our practice patterns. I would love to see more data. Let's talk about the maintenance strategy that's used here. And do you drop this patient, they dropped the pemetrexed after 3 cycles and then continued the pembrolizumab, or do you try to keep the pemetrexed and pembrolizumab going together for as long as possible?
I try and keep them both going together as long as possible. But I do think there is some cumulative toxicity, whether it be mild renal insufficiency, edema, fatigue, that sometimes comes with the pemetrexed. Generally, after cycles 4 and 6 in my practice, some patients start to lose some steam, and I will drop the pemetrexed if there's a reasonable toxicity that's impacting that patient's quality of life.
I was going here with my next question. You get to 2 years. Do you stop the immunotherapy or do you continue? I know you've been asked this 20 million times. It's a question that we always get asked. The data was, most of the trials, they stopped after 2 years. How do you have that discussion with the patient? Now, clearly this patient's not that. Now, this patient had disease progression on pembrolizumab. And we're going to talk about second line, but let's say this patient's on it for 2 years. What do you do?
So I try to address that up front in the first couple of visits, that we're going to continue this until it stops working or there's a side effect, or up to 2 years. Because I think a lot of patients want to know how often do I have to come back to the campus and get treated. I have stopped at 2 years. I think that's the way the trials were designed. And we know those people who make it to 2 years, really, the majority of them have a very durable benefit at this point. And so I'm not sure that there's going to be a lot of benefit to extending beyond 2 years. Okay. There's always going to be people that progress, and I've had my moments of doubt when I've stopped someone at 2 years, they've progressed maybe 6 or 9 months later. And so I think it's still an open question within the field in terms of what's the optimal duration.
Yeah.
And, other segments in the patient population that can get a shorter course and some that really need a longer course.
I think that's very well stated. What's the optimal duration? The other question that comes up now is what's the optimal interval in the era of COVID? and we have approval for these drugs, at least as single agent, as every 6 weeks rather than every 3. Is that something that is considered for even these patients on triplet therapy? Do you ever do every 6 weeks rather than every 3?
This is a good question. It's actually very relevant to my clinic because I generally do the every 3 weeks for the first 4 cycles. Then with COVID, I switched people to every 6 weeks, but a number of people have come back and said, no, I want that every 3 weeks. Yeah. I feel more fatigue, more muscle aches, and some other things. And I think it's very interesting. Now, of course, those people have been on every 3 weeks, so they might, if you start on every 6 weeks, you might just accept it as the way it is. But I think I'm interested to see how well the every 6 weeks is tolerated when we're talking about keeping people on a therapy for years.
Yeah, I haven't done it yet in my practice either, although I have colleagues who do it given COVID, and it is approved. And I have problems seeing patients less than every month in my clinic. I'm a little OCD about my patients, but I can understand why some patients may want to pull back in the era of COVID. One last question before we get to the real question, which is if this patient were PD-L1 greater than 50%, we know it was 10%. Your decision making, we've got Keynote 024, which shows dramatic responses with single agent pembro versus chemo, a median overall survival time close to 3 years, incredibly a non-driver patient population. And then we have Keynote 189 that benefited everyone. So we've got 2 options here generally. Your discussion with patients with PD-L1 greater than 50, do you use single agent pembro? Do you use the triplet therapy? How do you make that decision?
So I think when they're greater than 50, I kind of look at how symptomatic they are, because the triplet did have a higher response rate than the monotherapy. So if someone's very symptomatic and have a borderline performance status, and I think I have one chance to intervene, I'll use the triplet therapy. Outside of those circumstances, I'd say the majority of the time I use the monotherapy option at this point. So I think that's the preferred therapy for many patients because you avoid the chemotherapy toxicities. And they, like you said, they have very good outcomes.
Yeah. Interesting discussion to have with patients. All right, getting to one of the more unrewarding parts of our job, Dr. Stinchcomb, patients get either single agent pembro or carboplatin pemetrexed pembro or any of the other regimens that are now approved. We know that disease progression does occur. And really a dearth of data here on what to do. I don't think we have a single trial yet looking at large patient populations showing a winner here post immunotherapy with chemotherapy. What do you do in these patients in your clinic, and what's the discussion that you have? And then what would you do for this patient who's had disease progression now on triplet therapy? How do you talk to them?
I think I try to segregate the patients. There are a few people who've had like slow progression or algo progression. Those people, I will try some consolidation radiation therapy and then try and extend the immunotherapy. I can't say it works with great success, but I do think there are some small subset that can do that. There are a lot of people with diffuse progression where we really have to think about changing the systemic therapy. And I think that this is very difficult because I think our options go back to the docetaxel or docetaxel ramucirumab, which may have been exciting when they came out, but really are not that exciting intellectually or for the patients at this point. And with the promise of immunotherapy, I think that this has been a difficult clinical trial space because I think, like you said, there's not a clear path forward at this point or a clear combination. And this is the greatest unmet need in our field right now, I think.
Do you, and we obviously don't want to discuss which clinical trials, but do you have conversations to patients about clinical trials in this setting? Is this kind of a priority for you to make sure these patients are on clinical trials, or do you put most of your patients on docetaxel plus ramucirumab and wait for a third line clinical trial option?
So I try and get them on a clinical trial in the second line because I think that that's probably the best opportunity. And I kind of use the NGS to see if there's like a targeted therapy clinical trial that I could enroll in. Is there a novel immunotherapy trial at this point? I think the reality, though, is getting patients on trials is getting increasingly harder as the eligibility criteria increase as well. And I think it's been very challenging to do that. I wish I could say I put every patient on trial, but unfortunately, a lot of patients get docetaxel and docetaxel ramucirumab because they just don't qualify.
Yeah. All right. I'll ask you to put your nickel down because you're solely responsible for the recommendation for this case. Is it dosi or is it dosi ramucirumab?
He's fairly young, I think, and he maintains a good performance status. I would probably talk to him about dosi ramucirumab because it does have a higher response rate and progression-free survival, and I think he could tolerate the toxicities.
All right, one more nuance here. I'll put you on the spot. 60 milligrams of docetaxel or 75 milligrams per meter squared, or what dose of docetaxel? Would you start out the regular dose?
I would not start out the regular dose. I mean, I've just not had a good experience with that personally, and I generally start at 60 milligrams.
Yeah. It's exactly what I do off of a clinical trial. I do, ramucirumab plus 60 milligrams of docetaxel. This is, like you said, one of the biggest unmet needs that we have. Incredibly, all these therapies have moved to frontline, and what's been left behind is what to do for these patients second line. Doesn't mean we can't elicit meaningful responses second line with some of these agents, but it is a call for clinical trials and exactly what you said. I think it's a call for, understanding the criteria for clinical trials so these patients can go on. So in summary, I think we said that, the summary recommendation for this case is that this patient should receive docetaxel. We went a little bit further and recommended 60 milligrams per meter squared with ramucirumab every 3 weeks.